Okay, let's unpack this. Welcome to this deep dive. This one's really tailored for you, the advanced practice learner. Today we're tearing into chapter 24 of Pharmacotherapeutics for advanced practice. Big topic, asthma and chronic obstructive pulmonary disease, COPD, management strategies.
Yeah, and our mission here is really to give you that high-yield summary you need. We're pulling together the crucial pharmacologic principles, the MOAs, indications, contraindications, and importantly, those adverse effects you absolutely have to watch for. This is about managing these two um, really pervasive chronic respiratory conditions.
Right.
Think of it as the knowledge you need to feel confident prescribing, like right away.
And it's crucial, like you said, not just the drug list. We're grounding this in personalized medicine.
Right.
We absolutely have to get the difference between the patient's endotype,
Mm-hmm.
that underlying molecular
Yeah.
mechanism, and their phenotype,
Sure.
what we actually see clinically.
Exactly, because understanding that difference, it leads you straight to the theratype, which is just knowing which patient is actually going to respond best to which therapy. Get those three concepts down, endotype, phenotype, theratype, and honestly, you've pretty much won half the battle for prescribing correctly here.
Okay, so let's start with that foundation. Getting the diagnosis right. Asthma versus COPD. Let's talk asthma first. It's characterized by, well, variable symptoms, right?
Right. Wheezing, cough, shortness of breath,
Hmm.
they come and go.
And that intermittent inflammatory response.
And the absolute clinical anchor for diagnosing asthma is reversibility.
Hmm.
That's what you look for. When we do spirometry, we need to see that the airflow limitation isn't permanent. It gets significantly better after a bronchodilator.
So for adults, that's usually that 12% increase in FEV1 plus the 200 milliliter volume change.
That's the standard cutoff, yeah.
Yeah.
Or you might see just excessive variability in their lung function documented over time, peaks and valleys.
Okay, now contrast that with COPD. Here, the symptoms are persistent.
Persistent symptoms and critically persistent airflow obstruction. That obstruction just doesn't really reverse much, even if you give them a full dose of a bronchodilator.
And we confirm that post-bronchodilator, right?
Yeah.
When the FEV1 FEC ratio is still, what, less than 0.70?
Exactly, the actual measured ratio, less than 0.70. And while asthma often has that allergic component, COPD is usually, some genetic susceptibility plus environment.
Mostly smoking.
Overwhelmingly, yes. Tobacco smoke is the big one.
So if you're trying to picture the difference without the textbook table, just think. Asthma, your spirometry can swing back towards normal, peaks and valleys.
Right.
COPD, it's more like a permanently lower, flatter line. The damage is largely fixed.
And understanding that fundamental difference, reversible versus persistent, that's why the treatment strategies, GINA for asthma, GOLI for COPD, are so distinct it follows the pathology.
Okay, makes sense. So disease defined. Let's talk about actually opening those airways. Bronchodilators. You've got the
Fine.
short-acting ones for rescue.
Your SABAs and SAMAs.
And the long-acting ones for daily control. LABAs and LAMAs. Let's start with the beta-2 agonists, albuterol, formoterol, that group.
Okay. The key thing with these, the beta agonists, is speed. They hit those beta-2 receptors, which ramps up cyclic AMP, CMP, and more KMP means immediate smooth muscle relaxation in the airways.
They bypass all that gene expression stuff.
Totally. That's why they work so fast. Gives patients that quick relief they desperately need sometimes.
Which explains why the SABAs, like albuterol, peak in like 10 minutes, last maybe 3-4 hours.
Yep. Short-acting, quick onset.
But the LABAs, the long-acting ones, formoterol, someterol,
Yeah.
they last 12 hours or more. Now, why is that warning about LABA monotherapy in asthma so critical? You hear it all the time.
It is probably the single most important safety rule in this whole area. Using a LABA alone like salmeterol or formoterol for asthma maintenance, it's linked to an increased risk of asthma-related death. It's a huge deal.
Because you're just treating the symptom, the bronchoconstriction.
Exactly. You're relaxing the muscle, making the patient feel better temporarily, but you're doing nothing about the underlying inflammation. The fire is still burning in their lungs.
So for asthma, LABAs must always be paired with an inhaled corticosteroid, an ICS.
Always. No exceptions for maintenance therapy in asthma.
Okay. And systemically, what side effects are we watching for beyond just, shaky hands or feeling a bit jittery?
Well, because they can hit beta receptors elsewhere, you can get dose-dependent effects. Increased heart rate is common. You can also see hyperglycemia, potentially worsening diabetes control, and hypokalemia, low potassium. So definitely need caution with heart disease or diabetes.
Got it. Okay, let's switch gears to the other main bronchodilator class, The muscarinic antagonists, your ipotropium, tiotropium,
Yeah.
SAMA and LAMA.
Right. These work differently. They block acetylcholine at the muscarinic receptors in the airway. Blocking acetylcholine lowers cGMP levels, which also leads to smooth muscle relaxation, and it has an added benefit of reducing mucus secretion.
And the book pointed out this really neat aha moment about why these don't cause the same systemic confusion or CNS side effects as older drugs like atropine.
Ah, yes. That's the quaternary amine structure. It's a key design feature. They're built so they're poorly absorbed systemically and they don't cross the blood-brain barrier.
So the side effects stay local.
Pretty much. Primarily, patients complain of xerostomia, dry mouth. That's the big one. Maybe some upper respiratory infection type symptoms.
But still need caution with certain conditions.
Oh, definitely. Conditions like narrow angle glaucoma or prostatic hyperplasia, BPH. These drugs can potentially worsen those, so you need to be mindful.
Okay, airways open. But that's just step one, right?
Yeah.
Now, how do we actually treat the underlying inflammation, the anti-inflammatory agents? Corticosteroids first.
Corticosteroids, yeah. These are really the cornerstone, the foundation of controller therapy, especially for asthma. The mechanism is, well, it's complex. They work at the genetic level, inhibiting or inducing protein transcription to basically dial down inflammation. And importantly, they also make those beta-adrenergic receptors we just talked about more responsive. So there's synergy there.
And the timing is key here. They don't work instantly.
Not at all. Because they have to influence gene expression, the onset is delayed, hours, even days. And the full therapeutic effect, that can take weeks. That's a really critical point for patient education. They need to stick with it.
And for asthma, the guidelines are clear. Even for mild asthma, low-dose ICS gives the most bang for your buck.
Absolutely. GINA guidelines really emphasize that now. Low-dose ACS provides the most clinical benefit for the vast majority of asthma patients. Reduces future risk significantly.
But oral steroids, OCS like prednisone, that's different.
Very different use case. Oral steroids are reserved only for acute asthma exacerbations. Think a short burst, maybe 40 milligram prednisone daily for 5 days to get things under control quickly, not for chronic management.
Okay, but let me push on that a bit. What about COPD? If you have severe COPD, isn't inflammation a problem too? Why not use chronic OCS there? What's the major risk?
Ah, great question. The risk is all about systemic absorption and the severe adverse effects that come with long-term oral steroid use. Chronic OCS is basically contraindicated for COPD maintenance therapy because the likelihood of really serious problems, Cushing syndrome, steroid myopathy, or adrenal suppression, osteoporosis, glaucoma, it's just too high.
So OCS only for severe COPD exacerbations, short-term if absolutely necessary.
Exactly. Never for long-term control in COPD. For inhaled corticosteroids in COPD, the role is more specific, usually added in combination therapy for patients with frequent exacerbations or eosinophilia.
Okay. Now what about the leukotriene modifiers, the LMDs like montelukast?
Right. Montelukast, zafirlukast, Xiliton, these work on the leukotriene pathway. Xiliton inhibits the enzyme 5-lipoxygenase, while montelukast and zafirlukast block the actual cystinoid leukotriene receptors. The end result is preventing bronchoconstriction and inflammation driven by leukotrienes.
But clinically, they're generally seen as less potent.
Yeah, generally less effective than ICS or even the beta agonists for many patients, often used as an add-on therapy or maybe for patients with exercise-induced symptoms or concurrent allergic rhinitis.
And this is the class with that serious warning we absolutely have to talk about.
The neuropsychiatric effects, yes, this is crucial. There's a risk of serious neuropsychiatric events, including things like agitation, aggression, depression, sleep disturbances, and even suicidality.
So this isn't just a footnote on a consent form.
No way! You have to actively counsel patients and parents about watching for any mood or behavior changes. Given that LMDs are often less effective than other options, this potential risk really needs careful consideration in the risk-benefit discussion.
Definitely. Okay, moving into some more specialized therapies now. Niche uses, maybe higher-risk drugs. Let's talk BDE4 inhibitors. Roflumilast.
Roflumilast. This one inhibits the phosphodiesterase 4 enzyme, specifically within inflammatory cells in the respiratory system. By inhibiting PDC4, you increase intracellular NMP, which helps modify that inflammatory response.
And its indication is pretty specific.
Very specific. It's used to reduce moderate to severe exacerbations, but only in patients who have chronic bronchitis and severe or very severe COPD. It's not an asthma drug at all.
And the big red flag, the major contraindication.
Liver impairment. Moderate to severe liver impairment, so Child-Pugh class B or C. Its metabolism is heavily reliant on the liver, so this is a key safety check.
Okay. Now, what about the old workhorse, theophylline, methylene xanthines. It sounds kind of scary with that narrow therapeutic window and all the interactions. Why is it still around?
That's a fair question. It is a tricky drug. It's a non-selective PDE inhibitor, plus a weak adenosine antagonist. But it does something kind of unique besides just bronchodilation. It seems to enhance diaphragmatic contractility.
Ah, so it helps the breathing muscles.
Potentially, yes.
Yeah.
So for certain very specific, difficult to manage patients, that extra effect might still offer some clinical benefit when other options haven't fully worked.
But it remains a high alert medication. The metabolism is complex.
Extremely complex. It goes through multiple hepatic CYP enzymes, 1A2, 2E1, 3A3 mainly. This leads to a ton of potential drug interactions and interactions with conditions.
Like smoking. Doesn't smoking speed up its metabolism?
It does. Smoking induces the enzyme, so smokers often need higher doses. But then if they quit smoking, their levels can shoot up dangerously if the dose isn't adjusted.
And other drugs, like ciprofloxacin.
Cipro inhibits the metabolism, so taking Cipro can rapidly increase theophylline levels into the toxic range. There are many others, too.
Which is why you absolutely need serum drug concentration monitoring.
Absolutely. You're aiming for that really tight therapeutic window, usually 10 to 20 mg/l. Dosage has to be highly individualized and monitored closely.
Okay, let's wrap up the drugs by revisiting that idea of endotype and personalized medicine with the monoclonal antibodies, the MIBs, for severe asthma.
Yes, this is where treatment gets really targeted. If a patient has severe asthma driven by eosinophils, that's the eosinophilic phenotype, confirmed by high eosinophil counts, then we can use anti-IL-5 or anti-IL-5 receptor agents, things like benralizumab, mepolizumab, or luzumab. They target that specific IL-5 pathway driving the eosinophilic inflammation.
Precision medicine. But safety first, right. Luzumab has a black box warning.
It does. A black box warning specifically for anaphylaxis. This isn't a drug you just hand out a prescription for. It must be administered in a monitored healthcare setting where anaphylaxis can be treated immediately if it occurs.
And similarly for omalizumab, the anti-IG agent.
Correct. Omalizumab targets IgE, so it's used for moderate to severe allergic asthma, typically in patients with specific IgE levels between 30 and 700 IU/ml. It also carries a black box warning for anaphylaxis. The risk is lower, maybe around 0.2%, but it's still significant enough that monitoring in a healthcare setting is required, especially for the first few doses.
Okay, so we've covered the diseases, the drug classes. Now let's connect the dots. How do we actually apply this using the guidelines, GINA and GOLD-E?
Exactly. The guidelines provide the framework. For asthma, GINA uses that step care approach. You step therapy up or down based on how well symptoms are controlled and what the patient's risk factors are for future problems. And the core principle now in GINA is that every patient with asthma, even mild intermittent, should be on an ICS-containing controller medication. Usually as-needed low-dose ICS formoterol is the preferred reliever now.
Right, moving away from just SABA alone for rescue.
Definitely. SABA-only treatment is strongly discouraged because it doesn't address the underlying inflammation.
And for COPD, we use the GOLD-E guidelines. That involves looking at both symptoms and exacerbation history.
Right. GOLD-E uses a combined assessment. You measure symptoms, often with a CAT score, the COPD assessment test, and you look at their history of exacerbations, how many they've had, how severe they were.
Okay, let's make this real. Let's walk through that case study, MV, the 53-year-old account.
Okay, MV. He's got a 30-pack year smoking history, quit recently. Spirometry shows FEV1-FEC is 69% post-bronchodilator.
So persistent obstruction, that confirms COPD.
Confirms COPD. Now, assessment. He reports feeling short of breath daily. His CAT score comes back at 12.
Okay, CAT score 10 or more means more symptoms.
Right. And his exacerbation history. Only one respiratory infection treated at home in the past year.
So low risk for future exacerbation, 0 or 1 moderate exacerbation, no hospitalizations.
Exactly. So putting it together, confirmed COPD, more symptoms, CTAT 10, low exacerbation risk, that puts him squarely into GOLD-E Group B.
And this is the synthesis moment, right? We go directly from those clinical criteria Group B to the recommended initial pharmacotherapy.
Precisely. The GOLD-E strategy document tells us that for Group B patients, the initial maintenance therapy should be a long-acting bronchodilator, either a LABA or a LAMA.
So we could start him on, say, tiotropium, which is a LAMA.
Tiotropium would be a very reasonable choice. It's once daily, effective, and that potential benefit on mucus secretion might be helpful too. Or we could choose a LABA.
And his rescue inhaler would be?
A SABA, like albuterol, or maybe a SAMA-SABA combination, like a protropium albuterol, just for as-needed relief of acute symptoms.
Okay. And patient education for MV would need to cover?
Big things would be proper inhaler technique, making sure he can actually use the device correctly. For tiotropium, that's often a dry powder inhaler, so different technique than an MDI.
Right, slow and deep for MDI, quick and deep for DPI.
Exactly. Also, counseling on potential side effects like the dry mouth with tiotropium. And because he's an older male, mentioning the small risk of urinary retention, especially if he has underlying BPH, is important. Monitoring for that.
And we can't forget the non-drug stuff either. Device technique is huge.
Absolutely critical. If the patient can't get the drug into their lungs effectively, it doesn't matter how good the drug is. We need to demonstrate and have them teach it back. MDI, DPI, nebulizer, they all require different steps.
And immunizations.
Non-negotiable.
Hmm.
Annual flu shot for everyone with asthma or COPD. And pneumococcal vaccination is standard of care for all COPD patients. Usually involves getting both PCV13 and PPSV23, according to current CDC guidelines. Also recommended for asthma patients needing high-dose therapy or with comorbidities.
Okay, so pulling it all together, effective treatment really hinges on getting the diagnosis right. First, asthma versus COPD versus maybe asthma-COPD overlap.
Right. Then identifying the patient's phenotype or endotype where possible, especially for severe disease, and then strictly following those evidence-based guidelines, GINA and GOLD-D, to pick the right agent bronchodilator, anti-inflammatory, maybe a biologic.
It really seems to come down to that framework, finding the lowest effective dose of the right drug, delivered via the right device, to minimize those side effects and maximize their control and quality of life.
You summarized it perfectly. That's the goal. Okay, so as a final thought, something for you to maybe mull over, consider that special population, a pregnant patient with asthma. The chapter mentions and guidelines confirm that the risk from poorly controlled asthma during pregnancy to both the mother and the fetus significantly outweighs the potential risk from most controller medications, especially inhaled corticosteroids. So the provocative question is, how does that critical risk assessment balancing maternal and fetal well-being fundamentally shift the therapeutic calculus? Why are guidelines often recommending maintaining or even stepping up controller therapy during pregnancy and delaying any step down until after delivery? How does that compare to how we manage a standard non-pregnant adult?
That's a really important point about applying this knowledge in complex, high-stakes situations. Definitely something to think more about. Well, thank you for diving deep with us today into this really essential chapter on respiratory pharmacotherapeutics. Keep learning, keep questioning, and keep applying this knowledge safely and effectively.